Good morning. Thank you for giving me the opportunity to present our work at the SAGES meeting. The topic of my presentation is the outcomes of non-trauma splenectomy from nationwide inpatient sample. I would like to thank the Foundation for Surgical Fellowships for the support of this research. Since the invention of Leapfrog and other outcomes measurement organizations, there has been a push towards regionalization of surgical procedures that started in the early 2000s. And improved outcomes have been documented for some uncommon and complex surgeries, and also for solid organ resections, including adrenalectomies, hepatectomies, and pancreatectomies. However, the benefit for the more common general surgery procedures remains in question. So the goal of our study was to examine the effects of regionalization of non-trauma splenectomies. Our study was based on the nationwide inpatient sample, which contains discharge information for the stratified sample of 20% of all non-federal US hospitals. The data was analyzed for the years of 1998 to 99 and 2008 to 2009 using ICD-9 codes. All the primary non-trauma medically indicated splenectomies for the patients over 18 years of age were analyzed. And the variables that we were interested in included demographics, hospital volume, location and status, Charlson Comorbidity Index score, complications, and in-hospital mortality. The univariate and multivariate statistical analysis were used. We have divided the hospitals for the years of 1998 to 99 into equal terciles based on into equal terciles of high volume, medium volume, and low volume centers based on the annual number of non-trauma splenectomies that they perform. And over the next 10 years, there has been a shift. There has been an increase in the number of high volume hospitals, which indicates that regionalization has affected these non-trauma medically indicated splenectomies. There has also been a shift towards teaching in urban hospitals over these 10 years. This table summarizes patient demographics. So there were a total of 7,000 splenectomies performed for the years 1998 to 99 and 5,500 splenectomies in the years 2008 to 2009. On average, patients were older in low-volume hospitals in both decades. And also the Charlson Comorbidity Index score was on average higher in the low-volume hospitals, also in both decades. And the specific comorbidities that were more prevalent in low-volume hospitals were congestive heart failure and COPD. Length of stay tended to be higher for high-volume hospitals in both decades, and that difference was statistically significant for the later decade. The total number of in-hospital complications was not different for low-volume and high-volume centers in the years 1998 to 99, but they were slightly higher for high-volume hospitals in the later decade. But the in-hospital mortality was significantly higher for high-volume hospitals in both decades. We have then performed a multivariate regression analysis looking to identify the independent predictors of in-hospital mortality in the earlier and later decades. And these are all the independent significant predictors of mortality. And the most significant predictor of mortality in both decades was emergent admission. And that was followed by the high-volume hospital. So when we controlled for all the potential confounders, high-volume hospital was still a significant predictor of inpatient mortality. We have concluded, based on our study, that non-trauma splenectomies have been affected by regionalization in the early 2000s. The in-hospital mortality after splenectomy is multifactorial, but it's not a function of low-volume hospital. In fact, in low-volume hospitals, patients did better, even though they were older and had more medical comorbidities, although there may be an inherent selection bias in this. The strongest independent predictor of post-splenectomy mortality was emergent admission, and regionalization of splenectomy did not correlate with improvement in post-operative outcomes. Thank you.
Thank you. We'll take questions from the audience on this nicely presented paper. I do have a question for you. So did you assume that urban and teaching hospitals were interchangeable, or were they separate in your data collection?
So we actually looked at it both ways. I separated urban from teaching hospitals, and there has been a shift to urban, and there has been a shift to teaching hospitals. But also, most of the high-volume centers were urban and teaching.
Okay. And then I noticed in the abstract that you talked about liver disease as also a predictor of poor outcome, but I didn't see that in the
Yes.
slide.
If you look at specifically at the urban teaching hospitals, the number of severe liver disease, the number of patients with severe liver disease was significantly higher in those, but that difference was not statistically significant if you just look at the volume.
So there wasn't enough data to correlate severity of liver disease
Yes.
and outcome then?
Yes, based on hospital volume.
Okay. Any other questions from the audience? I don't believe we have any web questions or any text questions, except what time is lunch. So, but thank you very much.
Thank you.